Okay, looking at my watch, it's 5:02, meaning we are already 2 minutes late, at least according to Swiss standards. And welcome to the virtual Grand Rounds in Radiation Oncology. It's a pleasure welcoming you yet again after an exciting Estro meeting to our first webinar after Estro. You know our format, just giving you a very quick introduction. We aim to present you the latest science presented by top speakers from our field and also in a very interactive format. And we always present on the first Wednesday of the month, which is today in June, between 5 and 5:30. We keep our webinar to precisely 30 minutes to not steal too much of your time, to easily integrate it in your day-to-day clinical and research routine. We're always very thankful for the support and endorsement of our societies, the Estro Society, SASRO, and the DECRO Society. So many thanks yet again. Also reminding you that all meetings are being recorded. So if you do not make it, if you know a friend, a colleague who's super interested in pancreatic carcinoma, which should be everyone in our field, please be aware that it is being recorded and it's being available online. This is two slides which I have been using in my slide deck when I was member of the SBLT course from the Astro Society. This was in 2015, so about 10 years ago. And the background was a systematic review being done by Thomas Brunner. You know him quite well from the field of GI malignancies and pancreatic cancer. And at that time, he did a systematic review on what is the evidence for using SBLT in locally advanced pancreatic carcinoma. It was 20 trials, 720 patients, and the take-home message can be seen as follows. Higher doses of SBLT have a minor effect on local control, have an exponential effect on toxicity, and have a negative influence on the overall survival. So the higher the doses at that point of time with the technology and the target volume concept as being applied in the early 2000s, 2010 were detrimental for our patients. So I used this scheme here to illustrate the current status and the desperate feeling we had in the field of radiation oncology about pancreatic cancer. Kind of game over. I mean, if we deliver more and delivering less value for our patients, this is not what we aim to achieve. Luckily enough, we had people, colleagues, which didn't give up, which stayed in the field, which further developed technology, developed clinical trials, and were also strong in interdisciplinary collaboration. I'm super proud and honored to announce Marsha Reyngold. She's an assistant professor from the Memorial Sloan Kettering Cancer Center, and she reported about non-operative management not only of locally advanced, but resectable pancreatic carcinoma with ablative radiotherapy. Why is that being important? We know for patients having a locally advanced stage of disease, they have a poor prognosis, have a higher risk of metastatic progression. If we're having earlier cases, we can truly evaluate the local efficacy, the influence on overall survival in these patients having a higher competing risk for metastatic disease progression. So many thanks for giving us the insights into this analysis and also giving us the insights into your current plannings for follow-up clinical trials. So Marsha, many thanks again for joining and looking forward to your presentation.
Thank you so much for having me. I'm very excited to share our data and our thought process and hopefully find some collaborators. Um, so let me share my slides. Hopefully they're on the right in the right setting. So thank you for that wonderful introduction. I will be talking about ablative radiation therapy for pancreatic cancer. Is it an emerging alternative to the Whipple? In the future, I hope to title this talk Pancreatic Cancer in with the ablative radiation, out with the Whipple, but we're definitely not there yet. Okay, so I don't have relevant disclosures for this. As everyone on this call knows, pancreatic cancer continues to be a leading cause of cancer-related death in the world. These are data from GlobalCan, but of course, we know that especially in Europe and in the United States, it's one of the top 3 leading causes of cancer-related death. So it continues to be a problem. In terms of the treatment paradigm for localized pancreatic cancer, which approximately is 50% of all pancreatic cancer presentations, we know that it really depends on where you fall on the spectrum. For patients with resectable disease, meaning that there's no or very small amount of contact between the tumor and either the vein or the artery, the treatment of choice is surgery. So the Whipple procedure is the current standard for resectable head of the pancreas, PDAC. But we posit that that only benefits a minority of patients who undergo this procedure, and it's still quite morbid, despite a lot of developments that have been made to make this a better surgery to tolerate. So we think of pancreatic cancer, even at very early stages, as a systemic disease. In fact, about 80% will develop metastasis within 5 years after surgery, and 50% will happen within 2 years. If we look at real world data, 5-year overall survival after surgery is still on the order of 20 to 30%. Yes, we've seen some exceptional survivals in very select trials of adjuvant therapy, but that's a very selected groups. And the real world data is still after Whipple. It's still, I don't want to be nihilistic, but unfortunately, it's still low. So, and the long-term morbidity with this operation is still quite high, even when surgery is performed at high volume center. And in fact, if we look at enthusiasm for surgery, so these are data from NCDB, which is representative of the cancer population within the United States. So looking at the population of patients presenting with stage 1 pancreatic cancer from 2010 to 2016, only 40% are getting surgery for a variety of reasons. Of course, that probably implies that some of these patients are too frail, but it highlights a need, an unmet need to have a treatment option for these patients that perhaps is more palatable to patients who are frail. And so, of course, we would like to borrow from the treatment for unresectable disease. And that's to remind everyone, just disease where the tumor is infiltrating more than 180 degrees around the artery. And you're completely either occluding the vein that's not amenable to reconstruction or just a long encasement of the vein that's also not amenable to reconstruction. And up until very recently, we have seen that if we look at standard dose radiation therapy, of course, on the basis of now for randomized controlled trials, there hasn't been a consistent overall survival benefit compared to chemotherapy alone. And the median overall survivals in the modern era, in the trials done in the modern era, with standard dose radiation, median survival is on the order of 13 to 16 months, and 2-year overall survival rate from the time of diagnosis kind of bottoms out at 25% or less, depending on the trial. And of course, you just recently saw that the initial attempts to use SBRT and dose escalate were not successful. But recently, we feel that we now have been able to accomplish safe ablative radiation. And by ablative, we mean doses of 100 gray BD for BD of 10. And now we are excited about using that for lower stage disease. But first, just taking a quick look at the data for ablative dose. So this is from our prior publication looking at 119. These were the first 119 patients we treated with hypofractionated CT-guided approach within Memorial Sloan Kettering. So this is from 2016 through 2018 approximately. Median follow-up was over 2 years. And we saw that 1-year overall survival from time of radiation was 78%. 2-year overall survival rate from the time of radiation was 38%. Of course, you're not supposed to do cross-study comparisons, but this compares favorably to what we had seen with standard dose radiation therapy previously. And just to show you local regional failure, this is not perfect. We do continue to see failures, and at 2 years, local progression was 33%. So over the time, we're not the only ones who are doing successful dose escalation. And over time, 2 approaches have emerged. One is our type of approach, CT-guided hypofractionated approach, which was initially pioneered, of course, by one of my mentors, Dr. Christopher Crane. And this approach we continue to use to quite a large extent, 67.5 grain 15 fractions or 75 grain 25 fractions. And we use selective adaptation. We adapt about 10% of all cases responses based on what their cone beam CTs look day to day. The other approach that's probably gaining more acceptance now is the MR guided approach. And those machines, of course, have online adaptation capabilities. And since the early experiences, folks have really felt that it was safe to do 50 grain 5 fractions. So your true SBRT kind of an approach. And the experiences, I'm showing some of the experiences here. Of note, the SMART trial was done by the ViewRay Consortium. This was the first prospective trial of this kind of ablative radiation therapy, with the minor caveat that they did have about a third of patients who did get surgery after, but the 2-year overall survival from radiation therapy is pretty consistent across all studies who have used this approach recently. So 2-year overall survival, about 35 to 40% from time of radiation therapy, and very acceptable toxicity here. Some late toxicity is seen, but it mostly is all reversible and grade 3, not higher. So our hypothesis here was that in comparison to locally advanced disease, ablative radiation therapy may be even more effective for earlier stage disease. You're dealing with smaller tumors, so more likely easier to control with radiation therapy. Also, probably the interface between the tumor and the luminal GI tract is probably less, so you're less likely to underdose the tumor, and of course, also less likely to harbor metastatic disease, so more amenable to systemic therapy. So we were hoping to see even a better, outcome with regard to the effect of local control and survival. So in order to answer this, of course, we do want to do a prospective trial, but first we decided to look within our database of patients who were treated on our ablative departmental protocol and prospectively entered into our database, although this is a retrospective analysis. So we wanted to look at patients who were technically resectable, but did not undergo surgery for a variety of reasons, typically because they're medically inoperable or frail. So we identified 25 such patients. Median age was 80, as expected. About half of the patients had KPS less than 80. Tumors were small. Median size was 2.5 cm. And a median CA19-9 was fairly low, 160, although we did have some patients who had quite high CA19-9s. What is important in this cohort and different from the locally advanced cohorts is that use of chemotherapy was relatively limited. Less than half of the patients had what we consider to be standard systemic multi-agent chemotherapy, either modified FOLFIRINOX or Gem/Nab-Paclitaxel. And about half of the patients got either no chemotherapy at all or single agent chemotherapy. Then since this is a radiation oncology group, I've included radiation details. So the majority of the patients were treated with our hypofractionated approach in either 25 or 15 fractions, although we did have 2 MR-Linac patients in this group. The median GTV size was 18.6, but quite a bit of variability there. What's important to note is, so I'm showing GTV V100, GTV D95. Medians were about 80 in both cases, and you can see that the low end of the range is quite low. And this can be very surprising for a lot of folks who don't do these kinds of treatments. So I've included our specialized contouring planning that includes absolute exclusion of all OARs with a safety margin. And this is based on, all the very scary early data using SBRT in the upper abdomen. We knew that the risk of GI toxicity is pretty high. So it's really, really important to exclude all OARs from our PTV. So this is an example using a locally advanced case, but it's easier to demonstrate here, but the same applies. So if in blue here is the GTV, and that comes right up to the stomach or the OAR, you can see the PTV high dose in red. It puts a margin on the GTV, but not where the interface with the OAR is. We're completely excluding OAR with an extra safety margin. And the way we planned here, you can see the plan. This dose here, the dose cloud is restricted to the critical isodose line, where we think the Dmax is the limit of safety for the OAR. So for 25 fraction treatment in the upper abdomen, we think it's 60 gray. You can see that we end up having that dose of 60 gray 3 millimeters away from the OAR. So it's not touching, there's still a safety margin of 3 millimeters. But in this way, the GTV shown in blue is not fully covered, not only by the prescription dose, which is in green here, but also not even by this high gradient here. Part of it is not covered by these higher doses, but of course, everything is included in the microscopic low dose PTV, which essentially is what the standard dose would be. So this part of the tumor is severely underdosed by definition. So what were the results using this approach? So the results are shown here. We saw a 2-year local progression of 21%, distant metastasis-free survival at 2 years of 20%, and overall survival at 2 years from time of radiation therapy of 44%. Of course, this is consistent with our hypothesis. The local progression and overall survival we saw here is at least numerically better than what we see in the locally advanced group. Of course, the numbers are smaller here, but nonetheless, there is some early efficacy signal based on this. And of course, the distant metastasis-free survival we think is very consistent with the fact that we saw a very low use of multi-agent systemic chemotherapy in this cohort. So in the early surgical trials where you had no adjuvant therapy or single agent adjuvant therapy, the distant metastasis-free survival was similar, if not worse. So what about the responses? We do in fact see better radiographic responses here than in the locally advanced setting, as expected. We actually saw 2 complete responses, and I'm just showing also some of the great responses we have seen. In the locally advanced setting, when we do ablative radiation therapy, we often see stable disease. The tumors often become these fibrotic scars that are difficult to follow. Here, we do see a little bit more of radiographic response that we can actually measure. And then we've also looked at CA19-9. When we did a waterfall plot initially, we were very surprised. There were quite a number of patients who never had CA19-9 go down. It just went up. So we hypothesized it was due to developing metastatic disease. So we essentially grafted by whether or not a patient had developed metastatic disease within the time frame of the observation of the study. And all of them ones who had early rise, of course, developed metastatic disease. And you can see this in the spider plot. Actually, we grafted by how quickly metastatic disease developed. And we see the dynamic of CA19-9 rise does really seem to predict how quickly someone will develop metastatic disease versus have more, stable disease. And we think this has implications for how potentially these patients who undergo ablative radiation therapy for technically resectable disease, how potentially they may be followed and how salvage therapy may be decided. So in terms of toxicity, similar to what we had seen in the locally advanced setting, 2 events of grade 3 gastrointestinal bleeding that was reversible. We did see gastric outlet obstruction in one case here. So in conclusion, the 2-year local control rate of about 80% and 2-year overall survival rate of 44%. Compare favorably to previously reported data of using ablative radiation therapy in locally advanced tumors. We think ablative radiation therapy can be delivered with a favorable toxicity profile. The toxicity we see is primarily subacute and subacute/late and is reversible. And we do think that MR-guided radiation therapy or other type of online adaptive radiation therapy is probably key to improving the therapeutic ratio there even more. And so we do think that ablative radiation therapy it makes non-operative management a realistic option for patients with pancreatic cancer, similar to how we have seen non-operative management for a variety of other cancers emerge in the last several decades. So our next future directions and unanswered questions, the role of MR-guided radiation therapy, I think we're all excited about this technology, although it's not as easily available, but it does allow for an easier integration with systemic therapy. It's more palatable potentially for some patients who are, medic or a little bit more frail. Evaluation of response, is there a better way to predict response to adjudicate who needs salvage therapy and who doesn't. And of course, the most important question is we would like to test this idea with a prospective trial. So, what is the best design? Can you do a randomized trial of surgery versus ablative radiation therapy for technically resectable disease? You probably know in the US, we're not very good at enrolling patients to randomized trials, especially when one of the options is surgery. So, is there another design? We're thinking single arm ablative radiation therapy that potentially has one salvage option with surgery, or maybe patients based on a variety of factors. We decide, who should try to get salvage surgery and who doesn't, but something along those lines. And I would like to quickly just acknowledge a couple of people. Importantly, my two mentors, Christopher Crane and Luis Diaz, who are really instrumental in looking at this idea, and I think we're all working really hard to design the next trial. And I'm happy to take any questions.
Thanks a lot. Congratulations again for this very exciting analysis. Thanks for joining again. I don't see any question, which gives me the opportunity to ask myself because I have a number of them. Starting with some kind of technical kind of details, maybe also patient selection. Did you exclude GI infiltration before? So did patients have gastroscopy, duodenoscopy to exclude a GI invasion, or was that not done before?
Yeah. So in all of our ablative experiences, we do exclude patients with frank GI invasion. It was a little bit less relevant for this group because they're smaller tumors, and so we didn't come up. But in general, when we do the ablative radiation, we do exclude it. Yes.
Then there's an immediate question I wanted to ask later, but
Yeah.
thank Philip for asking the question about systemic therapy. I mean, when I saw the pattern
Mhm.
of disease progression, it's effectively you call it the old historical data of patients not having had chemotherapy before, so effectively selecting patients which already have metastatic disease. I think the distant disease progression was 40% after 6 months. But I guess the like kind of low use, or you called it limited use of chemo, is just
Mhm.
related to the age cohort you had, median age of
Yes.
80, isn't it?
Yeah, yeah, it was related to both age or sometimes patients refused.
Mm.
Yeah, some of the patients, the reason they came for ablative radiation was because they didn't want any sort of treatment that would significantly impact their quality of life. And sometimes patients' perception, is influenced by something else. But we had a few patients who said, I'm willing to do this radiation, but no chemotherapy. So it was both. It was because medically frail, but I think there were some refusals in there as well.
So potentially, hypothetically, if you would have the opportunity of designing a trial in resectable pancreatic carcinoma in patients which are medically fit, what would you give as an
Yes.
induction or kind of
Yes. So, I think based on the SWOG trial, we probably would be able to do either, I think it would be reasonable to do either FOLFIRINOX or Gem/Nab-paclitaxel. And you probably would do it for at least 4 months, 4 to 6 months, something along those lines. Whether there's, difference between FOLFIRINOX and Gem/Nab-paclitaxel, it's difficult to say. The data are conflicting, but those two are that and probably Nal-Urifax now, whatever you think of it, but those would be considered probably standard. And I think once we have, right now there are two sort of ongoing, very similar trials in resectable pancreatic cancer that are testing pre-op versus post-op chemotherapy. So I think the one, the PreOpanc 3, and then there's an alliance trial in the US that's very similar. So I think, based on that, I would have to say that probably we would say 6 months of FOLFIRINOX. Um, but if I were to design a trial to really just intellectually answer the question of, does ablative radiation achieve the same kind of cancer outcome as surgery, then we would have to do it in the same way. Do chemotherapy, ablative radiation versus surgery.
you also
I
mentioned?
think it will be difficult if the pre-OPANC and the Alliance trials show that post-op chemotherapy is better than pre-op, then we're in trouble.
There's another question about what
Yeah.
increases the safety profile. I mean, we have discussed quickly the high risk of toxicity in the earlier clinical trials, which
Yeah.
was maybe due to technology, but maybe also due to kind of overdosing of organs at risk. I think we have two questions, one on the technology, one on the organs at risk constraints. So maybe first on the technology, what do you think is most important from a technology perspective? Is it motion management, for example, which can be addressed by a CyberKnife system? Is it image guidance, for example, using MR? Or is it the adaptive kind of thing? Well, irrespective of what you do, the anatomy is so variable from day to day, you need the adaptive component. Obviously, the best would be all. But what
Yeah.
kind of from your perspective most important to maximize safety?
I think it has to be the adaptive component, I would say, because with both of the two ways that have been shown to be relatively safe, both our hyperfractionated component and the MR guided online adaptive component, where in both cases you are adapting. So it's just that we are adapting kind of offline. We do look at these isodoses to the doses we estimate the doses to normal organs, and we do change plans when we think that anatomy is consistently unfavorable in a way that's different from simulation. So I think it's probably the adaptation part of it. And for those who cannot do it online, I think it works reasonably okay as long as you do it in more fractions, you can do it offline. And so basically, halfway through the treatment course, we then evaluate how this patient has been, how the treatment has been going, and then we sort of adapt the plan based on that. So it's still the adaptation. So I think the adaptation component is really, really important here. And of course, precision of delivery is also important, but I think that the ability to adapt and to really ensure that you're not exceeding the constraint to the OARs, I think that's probably the most critical.
You made a very important comment. The goal of the adaptive process is obviously to maximize target coverage, but maybe even more kind of to not overdose the organs at risk. So make sure that whatever kind of anatomy changes, we do not overdose, have a hotspot in our GI structure, the duodenum. So what
Yeah.
is the dose constraint you apply to the duodenum in your 5 fraction regimen and also in your 60, it was 75 mostly used.
Yeah, 75 and 25. So we our point dose for when we do it in five is we try to do 33 gray, but we have allowed to go up to 35. We also have
That is
we
point
create
max dose. Sorry to
yeah,
interrupt. Point max.
yes, point max.
Okay.
And then we do have a PRV that we create around the OAR, and then we also restrict sort of the dose to 1 cc of that. And then so for 25 fractions, that D max point dose is 60 gray.
Mhm. And another question would be your target volume concept.
Yeah.
There's some data saying that maybe there's a benefit for elective target volumes. Do you apply that in your patients, or do you strictly kind of confine your target to GTV and then some margin and then some kind of, you called it, I think it was some standard dose target volume. But do you use a
Yeah.
CTV concept?
Yeah, we use a CTV concept for that.
Mhm.
We call it, standard or microscopic dose, kind of that covers the yes. So we always cover in both the when we do the fractionation versus um, the hyperfractionated approach, 25 or 15 fractions. We always include in the CTV all the peripancreatic kind of regions. So at least 1 cm on the GTV in all directions. And then we include the origins of the SMA and the celiac axis, and then also portal vein for head tumors, especially if there's any portal vein involvement. And then if it's a tail or body tumor, we'll also include the splenic hilum for in that CTV. So that area, when we treat in 25 fractions, that area is getting 50 gray. Or actually 45, I think now. 45, sorry, 45. We keep slightly changing the 45 gray. And then when we do that on our MR Linac, that area is getting 33 gray. But there's slight variation in how we do the contouring. We will exclude all OARs without a safety margin from that 33 gray kind of volume. So yeah, so there's a little bit of a difference how we contour between the two, but we always include a CTV that sort of covers the lymph node regions, but probably it's really more the neural networks that we're covering that probably what mediates a local spread.
But your heterogeneity between the fractionations already indicates, I mean, it is of
Yeah.
utmost important truly to maximize the safety aspect.
Yes,
So this is
absolutely.
kind of the top priority. And even if you're kind of jeopardizing and compromising the target coverage, not only PTV, but also on a GTV level,
GTV. Yeah.
local control rates is very favorable.
Yeah.
And that with a combined favorable overall survival and very acceptable toxicity.
Yeah. We've actually, on this topic, for a while, we were wondering, are we, accomplishing anything for these patients? For some of the patients, a huge part of the GTV, right at the border with the OAR, is undercovered. So we've always been interested in knowing, well, are these patients also benefiting? So we've looked very carefully. Of course, there's some trend towards improved local control when we look at patients who had better coverage. But that trend, even now we have data for a large number of patients, over 200 in that one analysis, we see that that trend has never become significant yet. So it seems that it's probably true as expected that the patients who have full tumor coverage probably do better, but it's not a slam dunk for sure. And there are many sort of explanations we have for that. One of them is, maybe it's the truly radio resistant cells are in the middle of the cancer and stuff at the edge. Maybe it's a little bit more radiosensitive. So maybe even, can control that with a lower dose, or potentially, because you're dealing with tumor stem cells. We don't know where they're located. So, we have all kinds of explanations. And although it does seem that there is a trend towards improved local control with better coverage, it doesn't necessarily mean that the patients who had poorer coverage will, definitely have a local recurrence within, a few years. So can local control be improved? Absolutely. But right now it looks that even in perfectly covered tumors, there's some benefit there. And I think the benefit definitely goes away if there is a significant GI toxicity. So absolutely, our most important goal, and I think this is very different from many of the other disease sites in radiation oncology, that we are protecting the OARs at all costs. And then tumor coverage is a secondary consideration here, not primary.
There's no better ending than what you could assume for such a webinar. A take-home message which is strong, which is very important for deliver kind of advancing that field. Marsha, many thanks. I was really excited by the data when I've been reading them, and even more excited about these talks. Thanks, huge thank you for joining our webinar, for being here, and I'm looking forward to see many more exciting trials from you in the future, and also happy to meet you at the Astro meeting, maybe if you're there.
Hopefully, yes. Thank you so much for this invitation. It was my pleasure to talk to you today, and looking forward to meeting you at Astra.
Everyone, thanks for joining. Have a good evening. Bye bye. And the next topic, of course, will be announced if we have a topic. We always try to keep that kind of very short to be really up to date, the latest evidence, the latest clinical trials for you. Have a good evening, everyone.